Good afternoon. I'm your moderator for this afternoon session. I am Dr. Irma Melissa Abara Borreros, a graduate of the Fellowship Training of Adult Pulmonary and Critical Care at the Philippine Heart Center Division of Pulmonary and Critical Care Medicine and a member of PLFHRD Incorporated. Before we start, a gentle reminder to all our attendees. You may type in your questions regarding the lecture in the chat box, and the speaker can answer them in the chat box, or you may personally communicate with the speaker by sending a message to the following email address. Kindly answer the evaluation form after the last speaker of the session. The link will be provided in the chat box. Our speaker is Dr. William E. Del Poso, who will give an update in the ventilatory management of acute respiratory distress syndrome. Dr. Del Poso is a member of PLFHRD Incorporated. He is a fellow of the Philippine College of Physicians, Philippine College of Chest Physicians, and the Philippine Society of Critical Care Medicine. He had his fellowship training in adult pulmonology and critical care medicine and clinical fellowship in interventional pulmonology at the Philippine Heart Center. He is currently the section head of the Department of Pulmonary Medicine at the Commonwealth Hospital and Medical Center and the chief section of bronchoscopy, diagnostics, intervention of the Division of Pulmonary and Critical Care Medicine of the Philippine Heart Center.
A very pleasant day to everyone. The ongoing pandemic has made us see more cases of ARDS, now more than the previous years. So I would like to talk about the important updates on the ventilator management strategies in ARDS. These are my objectives. ARDS is a major concern in the ICU with a resounding impact on morbidity, mortality, and resource allocation. What we have observed with ARDS, especially recently in COVID-19 patients, is that these patients present in the hospital with interstitial pneumonia, with ground glass opacities, sometimes associated with alveolar lung collapse. From a clinical point of view, these patients present with severe hypoxemia that may not be associated with dyspnea or tachypnea. This is why it has been called silent hypoxemia. Respiratory mechanics may be normal at this point. Later on in this picture may evolve to severe refractory hypoxemia, eventually associated with dyspnea, tachypnea, use of accessory muscles of respiration, increased respiratory drive, with increased effort of breathing and abnormal respiratory mechanics. And respiratory failure sets in, and patients need some appropriate forms of oxygenation support. Acute respiratory failure may present in a wide spectrum such that we see milder forms requiring oxygenation support that includes low-flow oxygen therapy and high-flow nasal cannula. As the disease progresses, we see the need for more sophisticated ventilation support, such as NIV, invasive mechanical ventilation, and later on ECMO. Let us now look at the studies that had the greatest impact on ventilatory management of ARDS. This is the ARMA trial, the landmark study back in 2000. The randomization was between the traditional 10 to 12 ml per kilo volume, tidal volume as control versus 4 to 6 ml per kilo as low tidal volume intervention. This trial showed a significant drop in mortality at 31% on low tidal volume ventilation compared to 40% on the traditional setting. We see a divergent graph beyond the 2 weeks of ventilation, which underlines the importance of proper ventilation techniques. What we see at this point is the impact of the reduction of ventilator-induced lung injury. In addition to this, we saw longer ventilator-free days and organ failure-free days with low tidal volumes. Here, I'd like to highlight an issue we see very often, as there are trade-offs in low tidal volume. We look at the oxygenation or PF ratio between the 6 ml per kilo that is in yellow and the 12 ml per kilo that is in blue. Patients on low tidal volume have lower oxygenation during the first few days of ventilation. If we consider oxygenation as a parameter of treatment, you might even say that oxygenation is worse with low tidal volume. However, we know now that oxygenation should not be the sole parameter in ARDS as a target, and oxygenation is not associated with better survival. We notice here that after about a week, the PF ratios become similar. Additional strategies like alveolar recruitment and PEEP were studied to improve oxygenation in refractory hypoxemia. Two strategies were later designed to balance benefit and adverse effects of PEEP in ARDS through the alveoli trial, and we know this as the higher PEEP and lower PEEP strategies. A recruitment maneuver was also done using a single sustained inflation of about 35 to 40 centimeters water for 30 seconds for the first 4 days. Looking into the clinical outcomes of both approaches, we saw that they are similar in outcomes, whether it is higher or lower PEEP that we apply. 3 large RCTs evaluated higher PEEP versus lower PEEP in ARDS and looked into their outcomes. I've already mentioned the alveoli trial, or the assessment of low tidal volume and elevated end expiratory pressure to obviate lung injury. The next is the LOVES trial, or lung open ventilation, back in 2006. And finally, the EXPRESS study, or expiratory pressure study, back in 2008. And although it is true that each of these individual studies, the alveoli, the EXPRESS, and the LOVES trial, not one of them showed a statistically significant benefit individually. But when we put all the pieces together and analyze the data, on moderate to severe ARDS, there is a signal for benefit. On patients with mild ARDS, say with the PF ratios between 200 to 300, there is a signal for harm. This clearly tells us to be careful with what we subject our patients to. Higher PEEP, therefore, may be more beneficial in patients with more severe lung disease. We have seen that recruitment maneuvers with sustained inflation for a period of time and higher PEEP through the LOVES trial showed a significant decrease in patients who died from refractory hypoxemia in those who received higher PEEP and recruitment maneuver with sustained inflations. Similarly, the open lung trial, or OLA trial, although a much smaller study, used the same strategy of a sustained inflation recruitment maneuver, but this time followed by a decremental PEEP trial to determine the least amount of PEEP to keep the lungs open. This is the first RCT to compare an OLA strategy using PEEP titration, using maximal compliance to select optimal PEEP to the ARDS network protocol. This study found that the OLA significantly improved oxygenation, lung mechanics, and driving pressure, and did not adversely affect duration of ventilation support and ICU and 60-day mortality in patients with established ARDS. In addition, there were no significant differences in major adverse events between OLA and ARDSNet protocol. On the heels of the sustained inflation recruitment maneuver comes the titrated PEEP, or staircase recruitment maneuver. The ART trial involved a recruitment maneuver using pressure control with a driving pressure at 15, then increasing the PEEP to 25 for 1 minute, and then 35 centimeters water for another 1 minute, then 45 centimeters water for 2 minutes. Then this is followed by a decremental PEEP using volume control and setting the optimal PEEP, which is the PEEP associated with the best compliance, +2. On the other hand, the permissive hypercapnia alveolar recruitment lower airway pressure, or FARLAP trial, used incremental PEEP as well on patients with moderate to severe ARDS. The combined open lung procedure, or COLP strategy, is started using pressure control at 15 centimeters water, ±3. Then PEEP was increased to 20 for 2 minutes, then 30 centimeters water for another 2 minutes, then 40 centimeters water for 2 minutes. Then decremental PEEP was done in decrements of 2.5 every 3 minutes, up to a minimum of 15 centimeters water if no desaturation occurs, or at the PEEP where the O2 saturation is reduced by 2%. In both studies, using incremental or staircase recruitment maneuvers, there was a signal for harm. Mortality was higher in the ART trial, whereas cardiovascular events were more frequent in the FARLAP trial. This leads us to conclude that in patients with moderate to severe ARDS, incremental or staircase recruitment maneuver is not advised. This brings us to that all-important question of who do we use our recruitment maneuvers to? The obvious answer is those who are recruitable. But how do we know who is recruitable? Gattinoni's paper is instructive in this aspect. Here is a CT of a stereotypical highly recruitable patient. We see large proportions of lung tissue with restored aeration as they open up from 5 centimeters water up to 45 centimeters water PEEP. As a consequence of this recruitment, the baby lungs get much bigger and oxygenation improves. Here now is a CT of a typical non-recruiter. We can see how different the starting CT scans look like. The patients who did not recruit much had most of their lung tissues open to start with. They did not have terrible looking X-rays and CT scans. You will not be able to recruit much because they do not have a lot of lung collapse to start with. So how do we now set up our PEEP? Higher PEEP may be better if the patient has more severe disease and are more recruitable. We look at the severity of hypoxemia with a PF ratio less than 150 and the response of lung mechanics to the PEEP with increase in respiratory system compliance and reduction in the dead space. We can then choose to use a lower PEEP in patients who have less severe disease and are less recruitable. We likewise consider to balance oxygenation goals and the level of PEEP with our hemodynamics. We can likewise titrate PEEP according to the severity of hypoxemia. That's the Love's approach. Use the stress index, that's the express trial approach, or use the esophageal pressure for FiO2 adjustments. We might also want to take a look at the individual response to PEEP. Golliger did this analysis, again, using the Love's and Express trial data as a secondary investigation. So this looked into what will happen to the change in oxygenation following the change of PEEP after randomization. Some patients had their PEEP increased, some patients had their PEEP decreased according to what they were on before the randomization scheme, and look to see what happened to their PF ratios and R after following randomization. So it turns out that if the PEEP was increased, there was a strong relationship between the PF ratio change and mortality. If the PEEP was increased and oxygenation improved, there's a significant lower risk of dying. So if PEEP was increased and oxygenation got worse, mortality went up, suggesting overdistension. As a control, in patients whose PEEP was the same or decreased, there was no significant relationship with that short oxygenation change and mortality. What now is the best lung ventilation strategy for ARDS? A systematic review and meta-analysis of 36 RCTs by Wang sought this out from 26 ventilation strategies for ARDS and its outcomes, here listed from A to Z. This includes, among others, low tidal volume and low PEEP, low tidal volume and high PEEP, with or without prone positioning, recruitment maneuvers or FiO2 adjustments based on pressure volume variations, pressure volume static curve guidance, esophageal pressure guidance, or any of the modes. Since multiple ventilation parameters are measured, a multiple treatment meta-analysis or network meta-analysis was used instead of a standard pairwise approach. This permits the evaluation of the comparative effectiveness of multiple interventions, even though some pairs may not have been directly compared, and has the potential to reduce the uncertainty in treatment effect estimates. So the results that this study generated shows us that compared with higher tidal volumes with FiO2 guided lower PEEP, pressure control ventilation with FiO2 guided lower PEEP, and lower tidal volumes with FiO2 guided lower PEEP and prone positioning ventilation are associated with lower mortalities in ARDS patients. The strategy that has the highest potential to reduce mortality is low tidal volume with FiO2 guided higher PEEP and prone positioning, which among the 26 strategies had the possibility of first rank at 61%. It maintains its rank for potential optimal strategies for ARDS due to improvements in mortality with the least amount of complications, followed by the strategy of lower tidal volume with pressure volume static curve guided individual PEEP, as seen in the Spanish trial by Pintado. The strategy associated with the worst all-cause mortality is permissive hypercapnia staircase recruitment maneuver and lower airway pressure demonstrated by the Farlap trial. It is viewed that during this recruitment maneuver, the resistance of lung vessels is increased, the transiently decreased cardiac output, and mean arterial pressure. A decreased tissue oxygenation saturation that occurs also causes harmful hemodynamic effects. Meanwhile, the strategy with the least risk for barotrauma is demonstrated by another individualized ventilation strategy using static pressure volume curve for tidal volume setting before doing any recruitment maneuvers. And strategies with using higher PEEP are associated with higher risk for barotrauma. How about strategies for oxygenation using non-invasive oxygenation support? This includes high-flow oxygen therapy and non-invasive ventilation. How much do they impact improvements in oxygenation and, more importantly, mortality? Patients with hypoxemia, especially at the beginning of the disease course, are often treated with non-invasive respiratory support, and we have several forms of these to be used. In this slide, we see the airway pressures and airflow tracings with different techniques as compared to spontaneous breathing with standard oxygen. For example, we have high-flow nasal cannula technique, where we set the gas flow, oxygen level, and humidity. With this technique, we can generate a modest level of PEEP. Then we have other forms of non-invasive respiratory technique like CPAP, where we set a single level of pressure around which the patient breathes, or non-invasive ventilation with two levels of pressure, the PEEP and pressure support, to further support the respiratory muscles and generate higher airway pressure. And these techniques may be used with different interfaces like face mask or even helmet NIV. Nasal high flow operates on several mechanisms to improve clinical outcomes in hypoxemic respiratory failure, leading to improved oxygenation, reduced lung injury, reduced diaphragmatic loading, and improved patient comfort tolerance. Non-invasive ventilation, on the other hand, has direct effects on oxygenation and unloading of respiratory muscles and can affect ventilatory control center or VCC in the brainstem in a variety of ways that includes beneficial and sometimes harmful effects on gas exchange, ventilatory muscle loading, and even cortical influences that are affected by the sense of dyspnea or anxiety. What we know about the use of these techniques in COVID-19 patients with hypoxemic respiratory failure arise from several guidelines issued at the global and European levels. As you can see, all guidelines in some ways support the use of high-flow nasal cannula, CPAP, and non-invasive ventilation techniques. In general, weak or conditional recommendations. However, most of these recommendations come from data collected from patients with hypoxemic respiratory failure before the COVID-19 pandemic. If we look at the current evidences with the use of these techniques, for example, a meta-analysis concerning high-flow nasal cannula versus conventional oxygen therapy used on hypoxemic patients, not necessarily with COVID-19, we see that it did not improve mortality. However, the use of this technique, high-flow nasal cannula, has significantly reduced the risk of intubation in these patients. Based on these considerations and the findings of 9 trials, the recent guidelines on the use of high-flow nasal cannula in hypoxemic respiratory failure recommends using this technique as compared to standard oxygen therapy, and this gathered a strong level of recommendation. What about non-invasive ventilation? Here, the evidences are more conflicting. This meta-analysis on non-invasive ventilation versus standard oxygen therapy by Rochberg showed no effect on mortality and intubation. This prompted the ERS and ATS guideline not to recommend the use of non-invasive ventilation for de novo acute respiratory failure based on the uncertainty of evidence. At this point, I think we should consider a couple of issues to better understand what kind of support to apply and how to apply this support to which kind of patients. The first issue is the severity of patients, for instance, based on the oxygenation or PF ratio. If we look at the secondary analysis of the results of the LungSafe study, a very large study about ventilatory management of patients with ARDS, both invasive and non-invasive ventilation, and focusing on the use of non-invasive ventilation, we see that in less severe patients with PF ratios more than 150, there was no difference in outcome. In this case, survival between NIV and invasive ventilation. However, in more severe patients, survival was lower with NIV. Essentially, the same results was seen in nasal high flow, although this was a very small retrospective study performed among COVID-19 patients in China. In this technique, the failure rate was different. Looking at the PF ratio, the failure rate of nasal high flow was very high at 64% in those more severe with PF ratios less than 200. And essentially, no failure rates were seen in those with less severe oxygenation. What we can derive from this data is that both non-invasive ventilation and nasal high flow may be safely applied on less severe patients, say with a PF ratio greater than 150. But we must be more cautious in using these strategies among patients with more severe lung disease. Another issue on the use of non-invasive ventilation concerns the interface that we use to apply this technique. We know from this RCT by Patel and coworkers that the use of helmet as compared to face mask for NIV in patients with severe ARDS was associated with a decrease in intubation rate, that is 62% in face mask versus 18% with helmet NIV. So this demonstrates the outcome difference in interfaces. From a technical standpoint, the most glaring difference between these two interfaces is the level of applied PEEP, which was significantly higher in patients who are on helmet NIV. Setting a very high PEEP was not possible with face mask NIV because of patients' intolerance and excessive air leaks. Applying a high PEEP with helmet was more comfortable for patients, and this allows the application of higher level of PEEP for a longer period of time. And this has beneficial effects not only in terms of improvements in oxygenation, but also in decreasing the additional lung injury produced by the patient's strong respiratory efforts or respiratory drive, leading to the so-called patient self-inflicted lung injury. Spontaneous breaths may worsen lung injury, particularly with increased respiratory drive. It is here that patients struggle to breathe, increasing their transpulmonary pressures. And what we see, its consequences of reduced alveolar pressure, pendulum, and increased esophageal pressure swings. Maintaining spontaneous breathing is good, but it also has its dangers. Transpulmonary pressure equals the difference between the alveolar pressure and the intrapleural pressure. In static conditions, pleural pressure is equal to esophageal pressure. We take this as a measure of the pleural pressure. So we encounter these problems during spontaneous breathing that aggravates the situation and propagates this vicious cycle of patient self-inflicted lung injury. However, under certain conditions, the application of PEEP decreases the respiratory drive. You can decrease the swings in esophageal pressures by increasing PEEP and reduce further lung injury. In this study by Yoshida, for example, a comparison was made between the effects of spontaneous breathing on subjects with low levels of PEEP versus high levels of PEEP during non-invasive ventilation. So what they found was that when spontaneous breathing was associated with higher levels of PEEP, the inspiratory force measured as swings in esophageal pressure was lower, being less negative, as compared to lower levels of PEEP. This observation was seen in both animal as well as human subjects. Inflammation is an important hallmark of lung injury, seen as higher uptakes or lighter shades of fluorodeoxyglucose uptake in these PET scan images. So high PEEP in this study was associated with a decrease in the inflammation observed in the caudal as well as dorsal zones, here marked as yellow areas in low PEEP and areas of which were reduced with higher PEEP. The beneficial effects of high PEEP can therefore be spoken not only in terms of oxygenation improvement, but also rendering the spontaneous respiratory efforts non-injurious. This recent meta-analysis by Ferreiro and coworkers suggested that in general, non-invasive forms of respiratory support may be beneficial in hypoxemic respiratory failure. Looking into the different techniques, the face mask, NIV, helmet NIV, and nasal high flow, the advantage of helmet NIV is clear as it improves mortality compared to standard oxygen. However, there is no direct comparison between helmet NIV and nasal high flow. This study seeks to do that, examining the physiological effects of nasal high flow and helmet NIV in acute hypoxemic respiratory failure in this study by Greco, Maggiore, and Antonelli. They examined patients with severe ARDS with PF ratios at 133 and applying nasal high flow at 50 liters per minute for 60 minutes, then helmet NIV with settings of pressure support at 12 and PEEP of 10 for 60 minutes. The main consideration examined is oxygenation through the PF ratios, secondarily with PCO2 levels, inspiratory efforts through swings in esophageal pressures, transpulmonary driving pressures, respiratory rates, and the level of dyspnea. What this study found was that in patients receiving helmet NIV, oxygenation was better. This was associated with a decrease in respiratory efforts or respiratory drive. Likewise, reductions in respiratory rates and dyspnea was more evident in helmet NIV as compared to nasal high flow. Interestingly, what this study found was that the decrease in inspiratory efforts obtained in helmet NIV as compared with nasal high flow was strongly dependent on the intensity of the inspiratory efforts during nasal high flow. So in other words, if the patients show strong inspiratory efforts or high respiratory drive while applying nasal high flow, applying helmet NIV significantly reduces these inspiratory efforts. And this was likewise associated with a significant decrease in transpulmonary pressures. However, if patients on nasal high flow have low inspiratory efforts, there is less beneficial effects in shifting to helmet NIV. The conclusion of this study is that helmet NIV can be more effective than nasal high flow, especially in patients with severe or moderate to severe hypoxemic respiratory failure and with vigorous inspiratory efforts or high respiratory drive. From this physiological study, we'll look into the application of these strategies to COVID-19. Recently, a multi-center RCT was designed and published in JAMA, and this is the Henivot clinical trial, which included patients with moderate to severe ARDS with PF ratios of 200 or less in 4 ICU centers in Italy. This study compared helmet NIV versus nasal high flow in patients with severe hypoxemia with the mean PF ratios of 102 and respiratory rates at 28. Helmet NIV was continuous for at least 48 hours, followed by nasal high flow set at 60 liters per minute, FiO2 between 50 to 70%, and as a primary outcome, it looked into the median number of days free of any type of non-invasive respiratory support 28 days after enrollment. These are the settings used for helmet NIV with high level of PEEP at 10 to 12. Pressure support was likewise at 10 to 12, and expiratory sensitivity or E-sense, and that tells the ventilator to shift from inspiration to exhalation. It was set at 10 to 15%, adjusted to avoid asynchrony. And helmet NIV was used using a ventilator able to deliver non-invasive ventilation with 2 levels of pressure. Leak compensation was likewise important, fast pressurization time, and adjustable expiratory triggers. As for primary outcome, there was no significant difference in terms of non-invasive respiratory support free days between helmet NIV and nasal high flow, with 20 days and 18 days respectively. However, looking into the secondary outcomes, which is the need for endotracheal intubation, this study found a significant reduction in intubation rates from 50% with nasal high flow down to 30% with helmet non-invasive ventilation. And the cost of endotracheal intubation was significantly reduced with helmet NIV, with less patients needing intubation for hypoxemia, respiratory muscle fatigue, or worsening dyspnea. Also, looking into secondary outcomes of non-invasive ventilation-free days, it was significantly higher with helmet non-invasive ventilation as compared to nasal high flow. What this means is that with helmet NIV, less patients need endotracheal intubation with longer days of not requiring invasive mechanical ventilation. For the key points of my talk, high flow nasal cannula and continuous high PEEP helmet NIV are the preferable techniques for non-invasive treatment of acute hypoxemic respiratory failure. Continuous high PEEP helmet NIV was may reduce the need for intubation, particularly in severe patients. And during any treatment, careful monitoring is needed not to delay intubation and protective ventilation. Optimal ventilation strategies for invasive mechanical ventilation for ARDS includes lower tidal volume with FiO2 guided higher PEEP and prone positioning, as well as lower tidal volumes with pressure volume static curve guided individual PEEP. Higher PEEP improves oxygenation and mortality among patients with more severe hypoxemia. Recruitment maneuvers using standard inflation or sustained inflations are more appropriate for patients with recruitable lungs and may reduce mortality in patients with refractory hypoxemia. And lastly, incremental or staircase recruitment maneuvers have a negative impact on morbidity and mortality. Thank you very much and have a good day.
Thank you, Dr. Del Poso, for that very informative lecture. Again, as a reminder to all our attendees, for your questions and clarifications, you may write them in the chat box and the speaker can answer them in the chat box, or you may personally communicate with the speaker by sending a message to the following email address. Kindly answer the evaluation form after the last speaker of the session. Link will be provided in the chat box. The Philippine Foundation for Lung Health Research and Development Incorporated, in cooperation with the Philippine Heart Center Division of Pulmonary and Critical Care Medicine, would like to award the Certificate of Appreciation to Dr. William E. Del Poso for being a speaker on the 12th Biennial Symposium, Exploring the New, Novel, Explicable Wonders in Pulmonology, given the 16th day of September 2021 at Quezon City, Philippines, signed by the organizing committee and the members of the Philippine Foundation for Lung Health Research and Development Incorporated. Please stay tuned for the Pfizer Dinner Symposium at 6:30 to 7:30 p.m. and the Macro Core Bridge After Dinner Symposium at 7:30 to 8 p.m.